Leadership in Needlestick Injury Prevention for COVID-19 Vaccine Delivery and Beyond. It is my pleasure to introduce our speaker today. Maureen Spencer has been an infection preventionist for over 40 years and is certified in infection control as a CIC. As one of the early pioneers in infection control, she was selected as one of the APIC Heroes of Infection Prevention in 2007. In 2012, she was selected as one of the Who's Who of Infection Prevention, and in 2017 was recognized as a Fellow of the Association for Professionals in Infection Control and Epidemiology for her advanced practice, prevention, and leadership within her field. Her previous positions have included Director of Clinical Education at Accelerate Diagnostics in Tucson, Arizona, Corporate Director of Infection Prevention for Universal Health Services, King of Prussia, Pennsylvania, Infection Control Manager at New England Baptist Hospital in Boston, and Director of the Infection Control Unit at Mass General Hospital in Boston. Maureen is currently an independent infection preventionist consultant and offers consulting and lecture presentations. Maureen has published numerous peer-reviewed publications and has presented many lectures at national and international conferences. At this point, Maureen, I'm going to turn the webinar over to you.
We're going to look at the current federal COVID-19 vaccination delivery and administration strategies and describe safety engineered device mechanisms. So we call those SEDs that comply with the Occupational Safety Health and Administration, or OSHA, requirements, and discuss opportunities to strengthen safety culture to prevent needle stick injuries during vaccine delivery and administration. So despite technology and initiatives to reduce needle stick injuries, surveillance data indicates an increase in sharps injuries in the US. These multifaceted challenges in the healthcare system is in response to the COVID-19 outbreak. Leadership must maintain the culture of safety within healthcare organizations despite current challenges, and the COVID-19 vaccine delivery and administration will provide unique opportunities for innovation in sharps injury prevention programs. So 2021, the year of the vaccine. So the emergence of these previously unknown pathogens such as COVID-19 highlights the critical role that the safety and health of healthcare workers play and the importance of protecting them from workplace hazards. As you can see, the percentage of visits for influenza-like illness have been reduced over the early part of the season. And this is most likely due to the success of infection prevention measures, such as the hand hygiene, the use of masks, social distancing, and environmental disinfection. However, the National Center for Statistics Mortality Surveillance System demonstrates the increase in the number of pneumonia, influenza, and COVID-19 infections and the mortality associated with them. And you can see that the percentage of death due to these three, pneumonia, influenza, and COVID-19, has increased dramatically going into 2020, and the blue on the graph represents those cases or those deaths that were due to COVID-19. With the ongoing COVID-19 vaccination programs, we might have a perfect storm for the increase in needle stick injuries. First, we have large-scale vaccination clinics being established in response to President Biden's call for 100 million COVID-19 vaccinations in his first 100 days of office. Non-medical personnel are being hired and trained to administer the vaccines. And the question is, what type of training is being provided to them? And mobile vaccination sites may not have occupational health on-site availability. And so are those that are going to be trained to administer the vaccines being told how to respond if they get a needle stick injury, as far as where to go to get care for that injury? We have our first polling question. If you or an employee sustains a needle stick injury while working, where is the treatment for the needle stick injury given in your setting? Do you have an occupational employee health clinic or a nurse? Would you be instructed to go to your emergency department, either at your facility or locally? Do you have an off-site occupational health clinic or other kind of a walk-in clinic you'd be instructed to go to? Or you don't know? So here we have some answers. So for 64% of you, you do have an occupational employee health clinic. Others are directed of 18% to the emergency department, or offsite clinics 10%, and about 8% would not know where they should go. So that's something we have to be aware of as we move forward with the vaccination programs. While the first phase of vaccination has begun in the United States, at this point, large-scale distribution isn't expected until the spring of 2021. The vaccine developers say that they'll have enough doses for more than 1/3 of the world's population by the end of 2021. So there are going to be some challenges. One is going to be staffing. And we already know many healthcare organizations are already dealing with staff shortages, or they're using a lot of agency nurses or a lot of travel nurses and staff. Other healthcare professionals are coming into the hospitals to meet the demands of patient care for COVID patients as well as immunizations. Storage and handling. Errors in vaccine storage and handling are a serious patient safety concern. Organizations must ensure they have the required equipment on hand and that everyone is thoroughly trained on the differences in the vaccines and how to properly store, prepare, and administer these different vaccine options. Distribution workflows. The Moderna, Pfizer, and AstraZeneca vaccines all require 2 doses given anywhere from 3 to 4 weeks apart. So it's important that you know when you get the vaccine what your protocol is for the second vaccine. So vaccine management systems can be useful for providers to establish workflows that account for these multiple doses, as well as the screening, the consents that have to be filled out, patient scheduling, and quick on-site registrations, and administering shots often in non-traditional locations like parking lots. In supplies, the health experts warn that once a vaccine for COVID-19 becomes available, a global shortage on safety devices needed to administer the vaccine could follow. And in the US alone, they're estimating that up to 850 million syringes will be used for vaccine administration. And then the other challenge is going to be the reporting and analytics as people get vaccinated across the country. The needle stick injury concerns prior to COVID-19. According to data collected between 1997 and 1998, the number of percutaneous injuries sustained annually by healthcare personnel in the US was 384,325. More than 1,000 injuries a day, despite all the efforts through more than 20 years of needle stick injury, state and federal legislation, and availability of safety engineered devices. Similar injuries also occur not just in healthcare settings, but you can have injuries in nursing homes, clinics, emergency care services, group homes, and private homes. According to the 2015 data from the Association of Occupational Health Professionals in Healthcare's Exposure Survey of Trends in Occupational Practice, Expo-STOP, they still estimate that about 300,000 healthcare workers sustained injuries in the United States. Subsequently, they collected data from 2016 to 17, and they showed the continued increase, indicating that the prevention of sharp injuries is in need of a really aggressive and relentless action. And over time, sharp injury incidents have decreased from injuries occurring from disposable syringes and winged steel needles or butterflies due to the advances in safer technologies. But we continue to see injuries, especially from sutures and scalpel blades that are used in the operating room. So healthcare workers impacted by needle stick injuries. So despite all the awareness, as I mentioned, and introduction of universal precaution guidelines back in 1987, after the HIV epidemic showed that healthcare workers could contract HIV from needle sticks. The exact number of the needle stick injuries that occur not known because many go unreported. Rough estimates indicate that it's probably more like 600,000 needle stick injuries are occurring each year because only about half are reported. Now, the majority of needle stick injuries are occurring in nurses, surgeons or surgical technologists, emergency medical technicians, laboratory personnel, and housekeeping personnel. So as I mentioned, needle stick injuries not only occur in hospitals, but every type of healthcare facility, like a clinic, an outpatient surgery, daycare, urgent care, nursing homes, and cosmetic surgery clinics. So here you can see Sharp's injury statistics from a 2017 report on clinical, economic, and humanistic burden of needlestick injuries in healthcare workers, published in Medical Devices, the Evidence and Research. The OR, 36%. And again, that's due to most of those are those suture injuries or a scalpel or another kind of a sharp injury in the operating room. But the patient wards are called nursing units, 34%. Outpatient settings, 5%, ICUs, 5%, the emergency department, 6%, procedure rooms, 3%, outside patient room, that would be the housekeeping, 1%, and then we have a category called other, where people did not report where they got the injury from. In this report from the World Health Organization, make smart injection choices prevent needle stick injuries. Now we look at the type of sharp injuries. And so the leader is in recapping needles. And that's our biggest concern about these vaccination clinics. If they don't have safety engineered devices and they have regular syringes, will they unknowingly, not knowing the risk, try to recap the needles? 18%. Taking blood, phlebotomy, 16%. Using a solid sharp, again, that's in the operating room, 15%. Disposing of the needles, 12%. Trying to get something to a needle box or into a full needle box is very often what happens. Handling rubbish, 12%. I just remember several in my career where the patient's family actually got a needle stick injury because they sat on a needle that was on the chair that somebody inadvertently left. Injections into IVs or arterial catheters, 11%. Administering percutaneous injections, 8%. And then it's interesting that there's one category here, activating a safety engineered device, 6%. And that's key, that if they don't have the education and in-servicing on how to use those devices, they may end up getting injured while they're trying to activate it. So before I get into this legislation, I'll tell you a little story about what happened in 1985. I was at that point the director at Mass General Hospital, and there was a report in the New England Journal of Medicine of the first nurse that actually got HIV from a blood gas syringe and that she injected into the palm of her hand. A few more cases reported right after that. So we had gone 5 years from 1980 when we first identified what HIV was and the start of the outbreak. And after 5 years, we didn't really think much of it, didn't think healthcare workers were going to get it. And back in those days, if you can believe it, they did not wear gloves when handling urine or feces. They didn't wear any safety glasses or gloves when they were suctioning or intubating. You would see surgeons walk around with blood on their lab coats. I mean, we just really didn't think there was much risk to us. Well, in 1987, the CDC published their first interim guidelines in the Federal Register called Universal Precautions, which has been later changed to Standard Precautions, but it was in the beginning called Universal Precautions. And the recommendation was that all blood and body fluid could be potentially infectious from all patients. So you had to consider when you're working with somebody's urine, sputum, blood, serum, tissues, that it could have HIV, hepatitis B, and hepatitis C, which came on a little further down the road. Includes the guidelines for handling and disposal of needles, scalpels, and other sharp instruments or devices. So that's what's so disconcerting, is to think this all came out in 1987 and then was enacted as regulation called the Bloodborne Pathogen Standard in 1991 from OSHA with the requirements for employers. So that if you were an employer that had employed any kind of staff that had to deal with blood or body fluids, you had to establish an exposure control plan and update that plan on an annual basis. And you must document annually consideration and implementation of commercially available and safer medical devices designed to eliminate or minimize exposure. So I was the chairman of the Needle Stick Reduction Committee back then at Mass General. And at that point, all the healthcare workers were finding some of the new technologies coming out and bringing them to our attention, and we would seriously consider them at the committee and then make those part of our exposure control plan under engineering controls, which we'll talk about in a little bit. 2001, the Needle Stick Safety and Prevention Act from OSHA was put in the general industry standards for employers of staff that are exposed to needle stick injuries. And so this is that you have to have consideration and implementation of new technologies when your exposure control plans are updated, solicit employee input on appropriate engineering controls, and maintain SHARP's injury logs. So those logs become the way, as I just showed you some data, where are they happening and what was the injury type from those different logs. So the incident trend graphics, these came from a recent report from Amber Mitchell from the International Safety Center, just recently published on moving the SHARP safety agenda forward in the United States, the 2020 consensus statement and a call to action. And again, this is very disconcerting to see blue representing the Massachusetts information from the Massachusetts SHARP safety surveillance system of the number of injuries. They seem pretty consistent from all these years. And then the rate per 100 occupied bed came down a little bit with the little boxes, the blue box graph. But when you look over the EpiNet number of injuries, so this is a national program where they're entering in all of the injuries, you could see that we started to trend down through 2005, 2006, even to 2011, 12, 13, 14, and then things started to increase again. And now you can see the EpiNet SHARP's injury per 100 occupied beds. So for those of you who are infection preventionists, when you're doing your infection control plans, there should be a section in that plan with in addition to your HAI statistics and data that you analyze and you evaluate on an annual basis. So you get the information from your employee health or occupational health team of how many injuries there were and rate based by 100 occupied beds, and then see where you're trending by benchmarking against papers like this. And that may then have to kick out, if you have a very high rate, as a priority for the following year in your plan when you then develop the action plan for the next year. So this is a good source of information, both EpiNet and this paper. So OSHA recommendations for SHARP for safety engineered devices is to minimize the risk of percutaneous injuries and the associated potential for disease transmission. And they state it requires development and implementation of a comprehensive SHARP safety program, including the evaluation and implementation of appropriate safety engineered devices. So OSHA's hierarchy of controls represents how employers should address the hazards in the workplace. Ideally, any hazard would be eliminated or physically removed as the most effective method to protect the healthcare team under the top of elimination. Unfortunately, SHARPs are not likely to be eliminated in healthcare, as you know. So healthcare providers must utilize the other solutions. The next one is substitution. So we can replace the hazard by using blunt fill needles, needleless devices to access vials, blunt suture needles. So there are different devices that are able to prevent an actual needle stick injury by having the needle blunted. There's also engineering controls where you isolate people from the hazard. That would include reducing exposures such as SHARP's disposal containers and making sure they are accessible right at the site where these devices are being used. And self-sheathing needles would be another example. So as soon as the needle's taken out of the skin, they can click on a cap or something that will then, or a sheet that comes over and covers that needle so it can't stick anybody. Administrative controls or work practice controls are changing the way people work, and they will reduce the likelihood of exposures. So an example of that would be prohibiting recapping of needles, and just really getting staff to understand the hazard and trying to do that. I just remember in my previous days, nurses taking a cap and putting it on their abdomen, and then taking the needle and trying to recap it that way and stabbing themselves, or they would have them in their pocket and the needle would come off. They were walking around with the needle waiting to get to a needle box, and of course that cap would come off and they'd get stuck in the groin. I mean, it's fascinating when you are an employee health nurse and sit and hear the stories of how people get a needle stick injury. That's all I can say. And the other is using PPE, protecting the worker with PPE or personal protective equipment. So that would be in addition to the administrative engineering and substitution, things like gloves and face shields and goggles where blood or body fluids might be aerosolized. That's another type of an exposure that comes under the whole, not necessarily it's a SHARP exposure, but that is a bloodborne pathogen exposure. If you get sprayed with urine or feces or fluids into your mouth or into your eyes, you have to report that. So that's why in those kinds of settings, especially in the operating room, your emergency department and the intensive care unit is where, or emergency medical technicians, obviously out in the field, where you may get exposed to body fluid splashes. So they should be using a lot of PPE to prevent that. Now let's talk about medication preparation. Medication should be drawn up in a designated clean medication prep area that's not adjacent to potential sources of contamination, including sinks or other water sources. Water can splash or spread as droplets more than 2 feet from a sink. A toilet, the plume is 6 feet. And in healthcare, we don't have a lot of toilets with lids on them. In your home, shut the lid down before you flush. But the problem with sinks in a hospital is that people put supplies next to the sink that can get wet, and sinks are not sterile. They can have many organisms in them. In fact, one of the things in the past we've used med rooms for research is to take swabs down in their drain, because we found the most resistant organisms would be hanging out there. And the reason for that is it's not uncommon for a nurse to draw up a syringe of, say, an antibiotic and drew too much up, and they want to get rid of the air bubbles. So, they kind of flick it and they might squirt it up into the air, but many of them will direct it down to the sink. So now these organisms get used to a very small amount of antibiotics and get resistant to it. So these areas have to be cleaned and disinfected on a regular basis. And anytime there's evidence of soiling, during my years as a surveyor, I would find these rooms in some situations were not being cleaned routinely because housekeeping couldn't get in. So you've got to really arrange with housekeeping to get the keys to get into this kind of an area. The other one is pharmacy. I would see challenges there, and also nuclear med, where they just were locked spaces, for security, and they didn't have access to them to do the cleaning they needed to do. So make sure there's ready access to the supplies you're going to need: the alcohol-based hand rub, needles and syringes and sterile packaging, and alcohol wipes. Also, parenteral medications should be accessed in an aseptic manner, including using a new sterile syringe and sterile needle to drop medications. Again, I'll tell you a little story. I had an outbreak of total knee infections with alpha strep. Well, alpha strep comes from the mouth. I mean, it's not like MRSA or Staph aureus. We think more a person being colonized, or might be in the environment. And, I finally had to go up into the operating room to kind of watch what was going on. And sure enough, I see the nurse taking one needle, and she had 3 vials of one of these pain cocktails, we call them. And she would draw up the first vial and use the same needle to drop the second one while she's in the operating with a lot of activities going on, a lot of movement, doors opening and closing, people talking. And then she drew up the third medication, took that syringe and took it a sterile container and squirted it in for the mixture, and then passed it to the field. And so we figured that was probably the source, because alpha strep comes from the mouth. And so it's, situations when we have outbreak investigations, we have to look at the organism and then think, how did those organisms get into a sterile joint during total knee surgery? And that was how it was. So you have to be very careful with using them. Sometimes you think, oh, what a waste. No, one needle, okay, per patient, per medication. And proper hand hygiene should be performed prior to handling any medications. Make sure you have clean hands before you even touch the vial. And another one I would see often is people would pull off the top tab off of the, the medication vial, and they wouldn't disinfect it because they thought underneath it was sterile, and it's not. So make sure that you do disinfect rubber septums with alcohol prior to piercing and drawing up the medication. Now, there are some devices that can reduce needle stick injuries during medication preparation, and those include needleless med prep cannula, a plastic syringe filling cannula, or blunt fill needles where the point is designed to easily pierce the top of the vials while it has an inability to pierce your skin. So again, this is an example of a really good safety engineered device that should be used for med preparation. Now, medication delivery. Plan for safe handling and disposal of shots prior to injection. Look around to see, do you have a needle box close by? And if you don't, how are you going to safely get that needle to a box? Keep handling of the shots to a minimum. Utilize whatever's available of the Sharps engineered safety devices at your facility. If you are a traveler or you are an agency nurse, you may come into a facility and not know what they have available or how to use it and activate it. So make sure that you ask about that. And so some of the examples of medication delivery devices would be sliding shields, hinge shields, barrel-based safety shields, syringe with a retractable needle, and accessory safety shields. So you can see in the pictures here some of these kinds of devices of what we're calling these safety engineered devices. Now we're going to have another polling question. How often have you encountered a safety device in practice that you did not know how to use? Frequently, occasionally, rarely, or never? So this is great that 52% said rarely. But again, that means that 33% occasionally, or 3% frequently, and 13% said never. So again, we're starting to see that there is a need in these programs for better education on how to use these devices if they're there at your facility. So medication disposal. As many as 1/3 of all sharp injuries are reported to have occurred during disposal activities. So to prevent needle stick injuries or reuse, safety mechanisms should be deployed after you use the needle and syringe, and it should be discarded immediately into the label puncture-proof resistant containers that are red and they're identified as biohazard, and needles should never be recapped. Even if you put that needle cap on the counter and try to shimmy it in, there still can be injuries if it slips, so they should go immediately into a dispenser. They're made from a very rigid plastic. If you can imagine back in those days of the needle stick injuries in the mid-80s, we used cardboard. We actually used cardboard containers for needle sticks. So nowadays, we've really got these rigid plastic, puncture-resistant, tight-fitting lids. They are labeled to warn of biohazardous waste inside, available in various sizes, and often and they should have a line that indicates when it's full. Another important thing is to see where they're mounted. I know of some needle stick injuries in children that in an emergency room, somebody had just taken one because it was full and just put it on the floor and didn't mount it, and they put their hands in it. You know, that's not uncommon sometimes that others who have addiction issues might try to get access to the boxes. So the vendors have come up with some very unique lids. One of them, in fact, that when it is full, it will automatically lock it, which is the best design there is. So that no more needles can get in, start sticking out, or people can't get their hand in there to try to pull medications out. So now let's look at some of the COVID-19 vaccine challenges in the development and delivery of this vaccine. So Operation Warp Speed, or OWS, the goal of that is to produce and deliver 300 million doses of safe and effective vaccines, with the initial doses available by January 2021. So we have, at this point, about 4 million people have gotten the vaccines with very minimal side effects. I just recently read that the Moderna vaccine only had 10 people get that very unusual anaphylactic reaction. If you go on the CDC website and look under vaccines, you will see all the data on the types of side effects. They're very, very common with vaccines, you know, feeling a little achy, maybe having a little bit low-grade fever and pain at the injection site. But we are starting to get the vaccines delivered now. And it depends on your state, you know, the access to it or the waiting list in order to get it. Also, this OWS is for strategies to accelerate the development, the manufacturing and distribution of the vaccines, therapeutics, and diagnostics, known collectively as countermeasures, and partner among components of the Department of Health and Human Services. So there's a collaboration between the CDC, the National Institute for Health, the Biomedical Advanced Research and Development Authority, called BARTER, and the Department of Defense. And so OWS also engages with private firms and other federal agencies, including the Department of Federal Affairs. So it's quite the operation, the vaccine distribution process. So the vaccine gets distributed from the two manufacturers, Pfizer and Moderna, currently are the two on the market, and are delivered in two different manners, actually. So Pfizer transports the vaccine drug product and the ancillary mega kits, they're called, to UPS and FedEx, and those are distributed directly to the administration sites. Now, the Pfizer has to be on dry ice and has to go into a freezer. They have, storage requirements for that particular vaccine. Moderna vaccine and ancillary kits are first staged at the McKesson distribution centers before moving to the states and jurisdictions through UPS and FedEx. And you can see all the different areas that they're going as far as the different sites that are receiving vaccines. So the Department of Health and Human Services recently contracted with McKesson to produce, store, and distribute these vaccine ancillary supply kits on part of the Strategic National Stockpile. Each kit will contain enough supplies to administer up to 100 doses of vaccine. Now, what these kits will include are needles in various sizes for the population served by the ordering vaccine provider. So again, we need to know what kind of needles they are, or if any of them are safety engineered devices and require some in-servicing on how to use them. There'll be syringes, alcohol prep pads, surgical masks and face shields for the vaccinators, COVID-19 vaccination record cards for the vaccine recipients, and needle information cards. So mixing kits with syringes, needles, and other needed supplies will also be included for the COVID-19 vaccine that require reconstitution with diluent or adjuvant at the point of administration. However, these ancillary supply kits will not include sharps containers, gloves, bandages, and the cold storage requirements as far as the freezers. So the one we're most concerned about is not having those sharps containers readily available at maybe some of these unique sites, as I mentioned earlier, like parking lots, to make sure vaccinators have immediate access to a sharps container for disposal. Let's look at some leadership issues during the public health emergency. It goes without saying that the COVID pandemic has placed unprecedented challenges on healthcare professionals and healthcare leadership across the globe. Early in the pandemic, healthcare utilization dropped substantially and telemedicine increased. There was also a lot of suspension of elective surgeries, and this has had a major impact and an economic downturn for the healthcare industry. The mid-year, we started to see more inpatient care started to rebound, and hospitals were allowing people to come back in. However, they usually do not allow a visitor. So hospitals still have very strict visitation policies that people can't come in as we used to and sit in the lobbies and wait for our loved ones who are undergoing surgery or going to an appointment. So they're just trying to confine and contain, which is so important in epidemic control. Confine and contain the virus. And one of the best ways is to make sure that we don't have extra people coming in who might potentially be asymptomatic and transmitting it. By the end of the year, data suggests that healthcare spending was down 2.4% as compared to 2019. So the COVID pandemic outbreak has led to an unprecedented mobilization of healthcare resources, including redeployment to healthcare workers within the hospital and from outside institutions. As I said, a lot of travelers and agency nurses are being used by many settings. In many ways, the pandemic has exacerbated all the well-understood challenges that existed in our sophisticated health system. So we're starting to see, we have patient safety committees, and we have infection preventionists collecting HAI data. We have other clinical outcomes that like slips and falls and med errors and skin breakdown and pressure ulcers and, pulmonary embolus. So there's, the quality department has a whole other set of clinical outcomes that are monitored. And there've been a few reports now coming out indicating an increase in CLABSI and CAUTI rates. We're anticipating that, and reports starting to come out on that. Also C. difficile, because they're giving for many of these patients who are in the ICU who have pneumonia, they might give them what's called empiric therapy, which can be anywhere from 2 to 4 antibiotics in trying to kill whatever bacteria might be in the area where they've got the COVID pneumonia causing a secondary pneumonia. And that's going to wipe out the microbiome, and then they can potentially overgrow with C. difficile. We also know through literature, many studies in the past, that isolated patients have 8 times greater risk of experiencing care complications, such as these HAIs, falls and pressure ulcers, or injuries, electrolyte imbalances, medication errors. And that's because healthcare workers really don't want to go into the rooms. And now, because of the shortages with PPEs, they've come up with some innovative ways to not go into the rooms. One of them, which probably relates possibly to the CLABSI increases, is they would then connect pieces of tubing from the patient's IVs or central lines, and the tubings would come out of the room to, the equipment. And this is on the floor. Sometimes the injection ports could be walked on as this tubing is, coming out of the room to the pumps. And their reasoning is they just didn't have enough PPE to be able to go in and out of the rooms to the bedside to handle the pumps, for the medications and so forth. So it's created some very interesting adverse events. And unfortunately, what's happened is there's been a decrease in adverse event reporting noted after March 2020. So as we start to transition the leadership into provided vaccination, there's a lot of staff challenges that they're dealing with. They are exhausted. I mean, there is quite a bit of burnout. The day in, day out use of an N95 respirator and safety glasses or shields and gowns and gloves in and out of rooms, seeing a lot of patients, dying. It's been very difficult for our staff. And we all know that, but it's been the challenge that leadership has to keep them going. And there are a lot of training challenges because of us bringing in a lot of agency or travel staff. And how do they know how these safety technologies work? They need a lot of education and preparing of the staff. We also have supply chain challenges. As we know, there were a lot of concerns related to the supply of PPE, syringes, needles, etc. Extra doses of vaccine in vials, but you might not have the supplies to deliver them. The manufacturers are currently focused on sustainable supply delivery with these governments supplying the kits, but no recommendation for stocking excess supplies for vaccine delivery for what they might need that's not in those government kits. So it's a bit of a challenge. Your supply chain directors are probably under a lot of stress as well. And then sustaining your sharps injury programs. What happens with outbreaks, we tend to divert all our attention, especially with this one, to it. And we forget about some of these other programs that have been in place, as you can see, back since 1987. So there's a lot of need for education and training about the risks of and options for mitigation of accidental injuries, including the proper use of safety devices, surveillance and reporting of the sharp injuries, immunization of healthcare professionals against hepatitis B, post-exposure prophylaxis, and monitoring and evaluation of the effectiveness of program implementation. And I just want to mention something about post-exposure prophylaxis. The vaccine is not considered a post-exposure prophylaxis. This vaccine allows your immune system to quickly recognize the coronavirus, the crown that comes in, the spikes that inject into the cells, to start to use your cells as a manufacturer of millions of copies of itself. So your immune system is able to very quickly recognize and get an immune response, and that therefore prevents you from getting a serious COVID infection. However, you can still get infected. You could still transmit COVID, and you still need to use the infection control measures of hand hygiene, use of masks. The mask is going to, if you are infected, prevent you from putting it out into the environment. And if you're not infected and you're near other people, the mask will prevent it from coming into your nose and your mouth and you inhaling it. We got the sanitizer or hand washing. We got the use of masks. We have environmental disinfection with approved disinfectants. And then more importantly, social distancing. That you keep yourself at least 6 feet away from people, but also they're showing now, CDC has just been publishing some reports that we're not really seeing that a lot of these in contact tracing report was just came out a few days ago, is showing not so much restaurants and businesses have been the source of people getting COVID, it's homes. It's when you're close together at a party or the holidays were a big issue. So that's what you've got to think about, is who you're going to have in your home or in a closed space who you don't know has it and potentially come down with something like COVID. We have a lot of opportunities for intervention. There's a lot of needs for training and education. So expand the scope of practice for healthcare professionals. So what's been really great about pharmacists and PharmDs that have come on the market, they can provide these vaccines. It was back in 1996, the pharmacists started to undergo the formal training for vaccine administration. And they can be used as a great group to be able to provide the vaccines, and hoping down the road, this is what will happen with the COVID-19 vaccine, that it will be available like the influenza vaccine, just down at your local pharmacies. So the problem is that there are some states that have regulations and pharmacist vaccine authority, and it can be very complex and varies widely among states. But pharmacists can be the bridge for the vaccination, for the COVID-19 vaccinations, and overcome the challenges. So CDC recommends using standard orders or protocols to ensure that the pharmacists are authorized to administer the vaccines. We also need additional training on, as I've said before, the safety engineered devices that are not currently being used, and the manufacturers' IFUs. And you'll hear IFUs often, especially with surveyors. Where are your IFUs? What they mean is your manufacturer's instructions for use. I ask that a lot when I go in, I see a piece of equipment and I ask the staff, where are the IFUs? What do you mean? Information for use. How do you clean this? What did the manufacturer tell you? I had a question the other day about, how should we clean our mobile devices and our computers? And my response back was, check the manufacturer's IFUs. Some of them don't want you using certain things on the screens. It may harm the screens, or on the keyboards, it may make them sticky. So we have to get used to just asking the manufacturer to provide you with these instructions for use for any kind of devices used in healthcare settings. So what we can do is resource stewardship. U.S. healthcare facilities have experienced substantial PPE shortages during the pandemic. So as I mentioned earlier, limit the number of patients and visitors. That's being done pretty much across the country. Utilize telemedicine wherever possible. I think it's wonderful to not have to go all the way into, Boston or to a doctor's appointment. I could just do telemedicine for a quick checkup. It's great. The face mask and the respirators, move face masks, remove giving face masks for visitors in public spaces. What's been happening is you'll come into an office, maybe you're coming into your doctor's office or into a healthcare setting, and many of them are giving out a clean one, making you take your cloth mask or your used mask off and giving you another one. We can probably stop doing that. Make sure that, that could conserve some of the face masks. Implement extended use of face masks, or really the respirators for the staff. So a lot of the N95s, there are several companies now that can take your N95s, and they're allowed by an EUA, emergency use authorization of the FDA, to reprocess your mask. Some use hydrogen peroxide and different kinds of disinfectants, and give those masks back to you. So it cuts down on the cost, the stocking, and the price that you're paying for all these N95s. And restrict for use only by healthcare professionals when needed as PPE. That's another thing that a lot of times people will use something, maybe an N95, where they could have just used a regular surgical mask. And isolation gowns is another one. What we want to do is protect our clothing so it doesn't get contaminated, and you don't take any kind of blood or body fluid that the virus might be still viable and bring that home and hug your kids or your significant others. So for patients that are high-risk activities, you're in the ICUs, you're working directly with COVID infected patients. Yes, it makes sense to have a really good isolation gown. But in other settings, what you might consider is using things that call them the bunny suits or coveralls, or reusable gowns. I know a lot of hospitals do that and send their laundry out to different laundry services, or even plastic aprons, work aprons, just so the front of your clothing is protected, while you're working with potentially infectious or asymptomatic cases. But for those in the high-risk categories, they definitely should have a good isolation gown. And so here's another one for resource stewardship. Don't dispose of sharps containers until they're full. A lot of hospitals set up just this routine discard, with EVS services, and then on a certain day at a certain time, they're just going to go in and take the the containers down and put another one up. And sometimes these may not be full. So that really takes teamwork, between the care providers and the EVS or housekeeping department to be able to let them know when one is full. And as I said earlier, the ones that automatically lock are probably the best, but you have to make sure you've got some backups to replace it, maybe in your utility rooms. Divert non-sharp objects to other waste streams where possible. If equipment is not saturated with blood or body fluid per the bloodborne pathogen standard, it does not have to go into the red containers, the biohazardous containers. They can go into even general trash. But if you want to be concerned about things like unbroken vials, putting those in another kind of a bag and sealing it up and putting it in the trash like you would do it at home if you had a mirror that broke or glass that broke. You don't have to put into a red sharps container packaging, the outside packaging of the syringe or the sterilization wrap or IV tubings and IV bags. Those can go into general trash. And so make sure that you use biohazardous waste bags appropriately. If it's saturated with blood or body fluid and you really feel that this equipment could potentially have blood or body fluid on it, yes, then you can use the biohazardous waste bags, but not the sharps container. I see that a lot of times we'd actually look in them to see what people are putting in there. And especially, as I said, with the vaccination program, we have non-medical personnel being the vaccinators. We have to make sure they understand that they don't have to put everything into the biohazardous containers and then get them full unnecessarily. Workplace ergonomics, assuring that sharps containers are within arm's reach in any location when needles are used, especially including pharmacy, medication prep rooms, patient care areas, and vaccination sites, and monitor the sharps disposal containers and properly get them removed when they're full and have backups there to get right back into use once those are going to be discarded. Some of the considerations for selecting a safety engineered device include a safety device for needles that keeps the hand behind the needle, has a feature of one-handed activation, provides full coverage of the needle, like some of them just snap right on top of it, or a resheathing device, as I showed you in those previous pictures, or it integrates safety device with the needle to prevent removal, so somebody can't take that needle off. You also want to make sure that your sharps containers minimize the potential for overfilling when the capacity is reached, limits accidental or intentional access to container contents, and allows visual monitoring. So many of them are not a solid red like maybe your biohazardous waste containers, but the needle boxes tend to be a little lighter so you can actually see if you're getting up to the fill line. Another important thing is to encourage your staff to report needle stick injuries and the new vaccinators, because nearly 6 out of 10 are not reported in numerous studies that have been done. These are some of the reasons that people say they didn't report them. They were just too busy at the time. That happens a lot of time in the ICU, emergency department, and the OR. They just can't break what they're doing at that time. They might be involved with the code. They might be in the middle of surgery. And so they just say, well, I'm just too busy right now. I'll go later. They have a fear of exposure to bloodborne pathogens. So therefore, they're afraid to even go and mention it, that they got a needle stick injury. We have a fight or flight response in our life. And some people the fear, just freezes them and they don't go. And others are fighters and they would say, I'm leaving right now and going down to employee health. I want to get my program going right now and get tested for bloodborne to see if I got any bloodborne pathogens in me from that needle. Embarrassment's a big thing. Sometimes people just feel so stupid from how they got the needle stick injury and they don't want to tell their colleagues. Lack of knowledge of how to report one and not knowing how to report the needle stick injury. And minimization of the seriousness of the injuries. I've heard that often, oh, I'm not worried about this little old 90-year-old lady. I doubt she has anything. And unfortunately, you find out, yeah, they had hepatitis C, from a transfusion they had way back before we were testing everything. Strategies to improve compliance with reporting. Ensure your employees know how to report the needle stick injuries. The assessment and treatment should be available 24/7. So if you have employee health or occupational health services during the day, very often hospitals will tell the employees, the supervisor will allow them to go down to the emergency room, or if you don't have an emergency room, which happens in some hospitals, then they go to maybe a local occupational or a walk-in clinic that they have worked with to get treatment. And streamline the reporting for needle stick injuries. That can turn people off. It takes forever to fill out the forms. So now we're getting there toward the end. We have another polling question. What level of confidence do you have that sharps injuries are being reported by your teams? Are you very confident that you report or your teams report? Somewhat confident, not at all confident, or I'm unsure. So this is great that 47% are confident that people are reporting their injuries. 45% is somewhat confident, not at all confident, 7%, and just 1% is unsure. So again, you can see that we still have challenges with the whole thing of getting healthcare workers to report their injuries. So we're coming to the end now and want to provide some resources for education that's available. The CDC has an interacting web-based immunization training course called You Called the Shots. It consists of a series of modules that discuss vaccine preventable diseases and explains the latest recommendations for vaccine use. Each module provides learning opportunities. There's a self-test practice questions, reference, resource materials, and an extensive glossary. There's also online educational offerings from most of these manufacturers. I would say all of them. You can get in touch with your medical device industry representative and ask them what type of educational offerings they have on safe engineered devices, how to use them, and how to prevent needle stick injuries. So the last polling question is, what types of resources would be most effective for educating your teams on safety needle and sharps containers? Training posters for your facility? Would safety best practice product training videos be the best, or live in-service training? So 10% training posters for your facility. I'm glad to see that it was that low, because research has shown that if a poster is posted, you might see it in the beginning, it catches your eyes, but then after that period of time, you actually don't even notice that that poster is there. So safety best practice product training videos, 48%, and live in-service training with direct on hand demonstrations is a very good type of training, a little challenging these days, but 42%. So thank you for those answers. I'm glad the posters was the lower one. In summary, the COVID-19 pandemic has provided opportunities for intervention and improvements in patient care and healthcare professional safety. 2 new COVID-19 vaccines are currently available, with additional vaccine candidates in various stages of approval. The federal government has aggressive goals for administering vaccinations over the next 3 months. However, increased vaccinations will equal increased risk of needle stick injuries if we don't do the in-servicing correctly and make sure people know how to use needles correctly and dispose of them. And it's really imperative for caregivers to utilize safe injection practices along with the OSHA-compliant safety engineered device mechanisms when administering vaccines.